which is actually the last session for the day. My name is Deb Harley. I'm a GP from the Geelong region, and I'm also the chair of the Geelong Palliative Care Special Interest Group. Before I go any further, I'd like to take the time to thank our sponsors for this afternoon, who are Ballarat Hospice Care and Grampians Region Palliative Care Consortium. So we encourage people to visit the sponsors' virtual lounge or portal and look through the resources that they have provided us today. Now, and this is a little bit controversial, but if you have any questions for our speakers, please put them on the live Q&A box on your conference app if you've managed to get the conference app working for you. And as Bianca said before lunch, you can actually upvote questions, which just means questions that are already on the portal, you can vote for them so that they're prioritised. So if more than one person is interested in having that question answered, if you vote for it, it'll put it up the scale of being answered earlier. And we'll endeavour to answer as many questions as possible throughout the afternoon. For general comments, you can use the discussion forum. Now, it is my privilege and pleasure to introduce the presenters of this session, which focuses on the challenges and opportunities that COVID created for the palliative care community. And by community, I mean the patients themselves with life-limiting conditions, their families and carers, the health practitioners looking after them, and the many others who are directly or indirectly involved but still play a vitally important role. I know that everyone has been affected by the restrictions that COVID has placed on us during the pandemic, but I think it's been particularly traumatic for those patients, often nearing end of life, who were compromised in their access to care, access to their loved ones if they were hospitalised, and the extra stress that this put on their loved ones, who often became Florence Nightingales overnight. Our health practitioners and support teams had to become innovative, flexible, learn and develop new skills, like working out how to use apps, and at the same time still look after themselves and their families at a time when few of us could guess what the next complexity of the pandemic was going to throw us. So we're so lucky in our region to have dedicated, skilled and highly motivated people looking after our vulnerable patients. And this afternoon's presenters will hopefully give you a little insight in the challenges they faced and still face and the outcomes that have been achieved to date. Our 2-hour session comprises a presentation from Jill Carter and Peter Eastman, along with members of their multidisciplinary team, and that's on team engagement and telehealth. And this will be followed by a case study from Dr. David Bromley, and concluded with a talk from Dr. Claire Hepper and Jeremy McKnight on compassionate communities and Shannon's Bridge. So, with further ado, I'd like to introduce our first speakers, and Jill Carter, who is a palliative care clinical nurse consultant. Jill is a UK-trained nurse, an oncology nurse, who's been involved in palliative care for many years, working across both the acute and community settings. More recently, she's focused on improving care to children requiring palliative care in our region, recognising the special hardships faced by the families and the carers. She's a regular attendee and contributor at our special interest group and illustrates the importance of multidisciplinary input to our conversations. Associate Professor Peter Eastman is Co-Clinical Director of Palliative Care at Barwon Health, and apart from being one of our local palliative care specialists, he's heavily involved in medical education at both an undergraduate and postgraduate level and has many strong research involvements in palliative care. So I'm just going to pass it over to them. Thank you.
Thank you, and thank you for the invitation. So I'm going to first of all talk about Lily. That's not her real name. She's a 17-year-old teenager with a relapsed GBM, glioblastoma multiforme. So the clinical summary is Lily was a 17-year-old girl with a GBM. She actually presented every parent's worst nightmare. She was on a school trip in Paris and she presented to hospital with terrible headaches and vomiting. She was treated conservatively and returned back to Australia after the excursion, only for that to all happen again, and then discovered with some prompt scanning of her brain that she had a GBM. She was diagnosed in 2018 and she had debulking surgery and radiotherapy, the standard treatment for GBM, chemotherapy, temozolomide. By February 2019, she had a VP shunt for raised intracranial pressure and further chemotherapy. And in March 2019, she was referred to our community palliative care team for ongoing support and care, given that she had relapsed disease. She had a residual right-sided deficit, which caused a lot of mobility and functional problems of her hand and her leg. She needed, although didn't always use, a four-wheel walking frame. She needed a wheelchair, lots of equipment at home. So pretty full-on supervised care 24/7. So her life prior to COVID, given the timings, she liked to keep home very separate from her illness. So she liked to actually come out to clinic appointments, and so that was how we set up. She had weekly hand therapy and physiotherapy at the McKellar Centre. She also had hydrotherapy weekly when she was able, when she was well enough. And I have to say, I don't put my bathers on for many people, but I did in order to assist this physiotherapist to get her in the pool, because to be weightless with that deficit was lovely for her and she really enjoyed that. And it became the highlight of her week. We made visits to the home. Obviously, we're a community palliative care team, but we also I set up clinic appointments and used to double up and go and see her at McKellar, because that was her wish, to keep us sort of separate. As most young 17-year-olds like to do, they love shopping, and she would still do that despite functional decline. She overcame a lot of body image issues and actually went out shopping in a wheelchair, which was a big thing for her. She also used to partake in a lot of the weekends away and all the services that were available to her. She'd done Make-A-Wish, the Have a Go program, doing all sorts of lovely fun things, family excursions, the zoo. She did some plate smashing to get rid of anger because she was cross about her diagnosis. And lots of fundraising for brain cancer. And she was the face of many fundraising events. She had counselling, face-to-face counselling, and she also tried to keep in contact with all her school friends, sort of normalising what a 17-year-old would do. Although she couldn't attend school, she wasn't well enough. She really looked forward to what they used to call the girls' nights. And maintaining all those social contacts and new activities, even though she had a terminal diagnosis and she was aware of that. So this is prior to COVID. And then the lockdowns happened. And all of a sudden, all of the above was gone. We were still able to visit if needed, obviously, and at the time we were all wearing full PPE. But what we also did with Lily is we did weekly telehealth on an iPad, just to be able to keep in contact and keep that engagement, because all of those therapies had gone. So they would do that too. They would link in with her online, and she would still do her exercises and her physio, etc., online. Luckily, she and her mum were very computer literate. She was very disturbed about her body image because of all the weight gain, because of the steroids she needed to be able to keep stable. So when we did telehealth with visual, she would actually only show half of her face because she was really conscious of what she looked like. So I guess that was a trigger to me. That is, is this, you can see yourself when you're online, and that obviously was quite confronting for her. So we had to keep that in mind, that not for everyone. It's not always a good thing to be able to see yourself. But it did keep us present and engaged. She lived quite a long way away, so it did keep us in touch with them and sort of able to sort of fully assess how things were going at home symptomatically when she was reasonably stable, and trying to adhere to the COVID restrictions and minimise risk to Lily and her family. As we all know, we all tried to do that for all our patients, didn't we? So reflections, whilst telehealth was very useful and advantageous for a while, it did become apparent that home visits and attendance to clinics were really necessary for her. And in fact, in the middle of all of the COVID lockdowns, she actually had her 17th birthday, and we broke the rules, and we did go and visit and had fun at her home. We took her the VR machine for her to revisit Paris on a virtual reality, which she absolutely loved. And I think that's it from me. I'll hand over to Peter.
We're not moving. Sure, yeah, so thank you. I'm going to, mine's a little bit duller. I'm going to follow on from what Jill's talking with an emphasis on telehealth and present some aggregated data, a study that we looked at or we performed early in the pandemic, trying to assess how patients and clinicians felt telehealth would work in a palliative care setting, and particularly in a community palliative care setting. So research team, the project was supported by Western Alliance Academic Health Science COVID-19 grant. And as Jill said, really almost overnight, the pandemic brought telehealth to the fore. Patients really shifted from almost 1 week having daily or regular face-to-face visits to relying on telehealth almost exclusively. And we do know there is some data that patient carers and healthcare practitioners do report satisfaction with telehealth broadly, including in a palliative care setting, but also that have highlighted multiple barriers to its effectiveness. And we felt it was important to understand both the patient and healthcare professionals' experiences with telehealth, acknowledging, at least at that point, that we thought there would be further pandemics down the track. This was in early 2020, and I don't think we envisaged that we'd still be in the same situation on one level as we are now. Telehealth broadly is generally thought of as the provision of personalised healthcare using any sort of telecommunication means, whether that's telephone, video conferencing, or any other remote monitoring technologies. And so all patients, both with our community palliative care team and involved in palliative care ambulatory care patients who were registered with the palliative care service between April the 1st and May the 31st, 2020, were eligible for participation. And those dates largely were the dates when Barwon Health stated that clinics were going to shift from being face-to-face to telehealth, and where the edict was largely that community visits should all be done via telehealth rather than face-to-face. So those patients and families were able to be involved, and we also involved any healthcare practitioners working in palliative care who had provided clinical services during that period of time. We developed a survey ourselves, and we tried to do it, given the stressfulness of the time, to be as non-burdensome as possible. And it did undergo some peer and consumer review. And we defined a telehealth consultation as any interaction lasting more than 10 minutes using technology with a healthcare practitioner. The survey was pretty easy to follow. It collected some demographic data, and then there were a range of questions looking at how people were interacting with telehealth, what sort of telehealth they were using, and how comfortable or otherwise they felt with using it. And there were free text options for people to be able to expand on responses. We use Likert style questions because they're easy generally to follow, and there's some examples of some of the questions that were asked. And people scored them between 1 and 5 depending on their preference for the question. And then we asked 3 additional broader questions. asking whether they felt the issues that they wanted to discuss were able to be covered during the telehealth consultation, whether their needs were able to be met, and what their preferred method of future community palliative care involvement would be, whether it was face-to-face alone, telehealth alone, or some combination of the two. And so the survey went to about 205 patients, and there were 78 responders, which was about a 36% response rate, which is pretty good for a written survey in a vulnerable population. And of those people, 64% reported that they'd used the phone alone, so that was the majority of patients. The average age for respondents was 75, so patients they were generally older people. The majority of patients responded that they didn't have any issues with telehealth, and 71% reported their needs were able to be met, although they did report a range of different problems, and these were largely around pre-existing problems with sight or hearing, problems with the technology, and sometimes feeling undereducated in relation to the technology. Interestingly, concerns around health information privacy was very, very limited reporting of that, and most patients either favoured or were neutral regarding their preference for face-to-face visits over telehealth. Healthcare practitioners, on the other hand, reported slightly different results. So 18 healthcare practitioners responded, and a third of those were nurses. And most had used, 3/4 had used a combination of telehealth and video conferencing. And again, all reported problems with both or issues with both, but the issues were quite different. So with telephone calls, generally it was concerns around an inability to observe body language and facial cues and difficulty establishing relationship. Whereas video conferencing issues tended to be more around concerns about how patients are engaging with the technology and the technology itself. The vast majority of the health practitioners preferred video conferencing over telephone calls, and all preferred face-to-face interactions over telehealth. When both groups were asked what their favoured future model was, interestingly, a combination of both face-to-face and telehealth was significantly popular for both groups, 60% of patients and 89% of healthcare professionals. So just summarising the findings, we thought this was interesting because a lot of the previous studies of telehealth have looked at pre-existing programs or programs set up specifically with analysing how people respond to them. And this was really real time because patients went from having face-to-face contact to telehealth involvement almost overnight. The majority of respondents, whether they were health practitioners or patients, felt comfortable with telehealth. Patients generally were ambivalent about their preference between telephone calls and video conferencing, whereas healthcare practitioners very much favoured video conferencing. And both groups reported issues, but the number of issues and the types of issues differed between the groups, like I said. So for patients, the main issues were around pre-existing sensory issues, technological problems, or experiential issues. Whereas for health practitioners, it was much more about the therapeutic interaction. And it's interesting that that really wasn't something patients mentioned really at all. And one of the things I postulated about that was I suspect patients were just happy to have some contact with healthcare practitioners in that environment, and maybe even more so one that, while they still had contact, didn't put them at risk of COVID, because again, we were at a time where we really didn't know what was going to happen in the future. And interestingly, the majority of both patients and healthcare professionals indicated their preference was for a model that combined both face-to-face contact and telehealth consultations, which has some implications in terms of how we plan our services moving forward. Thank you. Sorry for that. So now we've got a couple of members of our team who are online. Matt Ely, who's a physiotherapist who works for the palliative care service, and Bonnie, who's one of our occupational therapists who works for the palliative care service as well. And Matt and Bonnie are going to, well, we've talked, Jill's presented a sort of a patient perspective on how things worked. I've sort of presented some aggregated data, and Matt and Bonnie are going to talk a little bit about individual clinicians and how they dealt with the situation. Thank you.
Right, thanks, Peter. Just going to share. Sorry. Sorry, there we go. Okay, so hi everyone, I'm Matt. I'm a physiotherapist in palliative care.
I'm Bonnie, I'm an occupational therapist in palliative care.
And just as Peter said, we're going to just talk about how we adapted during COVID and our use of telehealth. So just to give you a little bit of background, so the role of physio and palliative care is really about providing advice and education to help people keep doing the things they want to do for as long as they can. So that's generally about advice about exercise, mobility, equipment, and as well as strategies to help manage symptoms like breathlessness and pain, fatigue. So that's kind of what I do.
And occupational therapy in palliative care, we focus very much on being as goal-directed as possible and what is meaningful to the patient and the family. This includes things like, everyday tasks such as people, showering, dressing, making meals, and, can be going out in the community, hobbies, all sorts of different things. And ways that we try to address that can include anything from looking at someone's home environment and equipment to care training or some symptom management around breathlessness and education there. Yeah, it's basically us.
Okay, so if we just look at what the traditional or the model of the trajectory of functional decline for patients in the last 120 days of life, this is typically the types of patients we see where so the vertical axis here, we're looking at the Konovsky, so it's basically a functional measure. So anything greater than 60 patients are able to care for themselves, and less than 60 they're needing more assistance and spending more time resting and in bed. And as you can see, obviously over time there's a relative period of stability, and then things start to deteriorate more rapidly as they near the end of life. Now, we like to think of where we do our work in kind of three main phases. So this is prevention phase. So it's really, this graph doesn't really identify it clearly, but more the people around 60 and 70 and above is where we're working to try and prevent or to slow down any functional decline, keeping people doing things that they can do for as long as possible. There's a point then they move more into a safety phase where we're looking at equipment, gait aids, falls prevention, things to keep people safe, keep them at home if they want to be at home, and hopefully avoid hospital admissions from things that we can avoid. And then as they deteriorate even further, then we're looking more at a comfort phase. So that's when we're sort of sitting, making sure the home is well set up for end-of-life care, looking at hospital beds, pressure care, mattresses, etc. And so that's kind of the three phases that we work across. Then COVID happened. So that was our normal business. So what did we do?
Yeah, so COVID happened, and like many people, we had to essentially redefine our practice. We were told to only do essential visits, and so we had to go back to the drawing board and actually figure out what that meant for us. So when looking at our model of prevention, safety and comfort here, it was clear that the safety and comfort was the essential part for us. So basically anyone who was deemed a high risk of a hospital admission, people that, were a really high falls risk, had very risky home environments that needed attending to, equipment provision to get them through those final stages, high risk pressure care, and looking at lots of carer training in that end of life phase. So I guess, we started to see over time that through going out on these essential visits that people could potentially have been slightly better set up if we were doing our normal practice and attending to the prevention part of it. And so we had to think about how we could keep doing the prevention part of our job, which really as OTs is a a big part of it and our bread and butter. So I guess it's good to go through what some of those things are, which is what was deemed non-essential at the time, but symptom management, including breathlessness, looking at fatigue with people, falls prevention, looking at supervised exercise with people, home environment assessments. Obviously, we're still doing these on the essential visits, but it can really make a difference if we can go in early to someone and set up their environment nicely for them and look at equipment. And we also have a bit of a mindfulness program in palliative care with people. Yeah, so how did we adapt?
So, could the answer be telehealth? Probably self-evident from this talk that it was. When we're talking about telehealth, we're actually talking about video conferencing, because a lot of the stuff we do normally as part of our routine triaging and assessing and monitoring patients is via telephone. So we kind of felt we did that already, so we're just adding in the video conferencing to add a new aspect. So some of the things that we did was adapt I was running a group exercise session at one of the local Bowen Health gyms. And during that time, we were able to switch that over to telehealth. The reason that was quite easy to do is because I already knew a lot of the people that were attending. They were all comfortable with each other. They'd met each other in the gym. So it was quite easy to switch that one over from sort of a gym session onto a telehealth. We did have to set some ground rules around things in terms of, as you would in the normal gym, where we talk about, if you want to talk about anything private, then just to raise your hand or to flag it, that we can have a catch up afterwards, that we kind of have a informal confidentiality agreement, that if we're talking about things, that kind of stays within the group. And the other benefit of seeing people in these telehealth exercise groups is that if they did raise concerns about symptoms and needed to see one of our nurses or have a chat to someone, it was quite easy to tee that up for after the session, or even if they flagged something for the OTs or anyone else, we're able to get that followed up. In addition to the supervised exercise groups, I also ran some one-on-one reviews with patients. So now I had one lady who had end-stage COPD, who was also coming along to the gym to see me one-on-one, and she really got a lot out of doing the one-on-one gym exercises, and we're able to set it up with a bit of help with her husband and getting the computer all well set up. But she was able to sit down and do I mostly see the based exercise program with me, and we could also monitor her breathlessness and work on those strategies. The other thing that we switched early on in the pandemic was switching the cachexia clinic to telehealth. So rather than people coming in, obviously there's a high risk when you have 4 clinicians, a patient and the carer all sitting in one room. That was able to be switched pretty easily to telehealth. So we would have the 4 clinicians and the patient all on different computers in different rooms. Some people work from home. We would send out all our questionnaires electronically. There were some physical assessments that patients were able to do on their own at home, which was easy for them to follow, like written instructions. And then we could still be able to provide the advice and ongoing reviews that they needed and keep those people engaged during the pandemic. During that time, we also had, I think it was Telehealth Awareness Month at Bowen Health, and they did a profile on one of the fellows that was coming along to the exercise group with myself and one of our students, I think, is in that picture. The highlights of what he loved it. He thought it was great. He felt it was easy to use. Obviously the comments are in red there, but my favorite comment is telehealth has been better than the alternative, doing nothing during the COVID-19 pandemic. And that was generally the feedback I got from a lot of patients is that they, not only did they enjoy doing the exercise, but they just enjoyed doing something rather than sitting at home.
And in OT, so for me, I'd never used telehealth before, so I had to first off figure out how to do that, and then start using it with people. So one of the ways we used it in OT was running a mindfulness group, which similar concept to how Matt was describing with the exercise group. It was around setting some rules for people and I guess just giving them that option. We also found that you could do quite a bit in terms of an assessment of someone's home environment with telehealth. I'd get people to take me around their house and show me their, shower, their bath, their toilet, what their chair actually looked like. And I don't know if you can see this photo that we've got on the slide on the right here, but sometimes an actual image is worth 1,000 words. If someone says to me, I've just got a little step into my shower and I've got a rail there, but in actual fact, it's a weird big step in and the rail's not really a rail. And so being able to do it this way actually helped us establish if it actually was an essential visit for someone and we would need to go out there. But most of the time it really helped us to better be able to provide our education. And if we were sending equipment out to somebody, which we did a lot, we would deliver equipment and drop it off at someone's doorstep, so there was no contact with them. But we were actually able to give out the right equipment because we've seen the environment through telehealth. And then we could even actually do a follow-up telehealth session to help someone and make sure that they'd set up the equipment appropriately in their home. It was definitely a different way of working for me. Also did some supervised exercise in OT space. That's probably a bit more around some upper limb programs that we did with people. And general education could definitely be done over telehealth, so things around fatigue management and breathlessness management. Yeah. I think that's you, Matt.
Oh, it's me, sorry. So how is telehealth part of the picture now? Obviously we're out of the pandemic kind of, but telehealth is still part of what we do. So we still utilize telehealth in cachexia clinic, not as routinely as we were. So obviously it's an option for anyone if they obviously can't make it in to see us at Andrew Love or at McCullough. So people who live sort of out in the fringes of the Bellarine will sometimes use it. Patients from Colac and Polo Bay, we often get those type of people rather than having to drive a whole sort of hour and a half in. We can utilise and still offer them the clinic in that way. And in a clinic setting, again, we still don't want to be having 4 clinicians plus a patient and a carer all sitting in one room together. So what we utilise is multiple different rooms when we can get them, or different computers, and we'll kind of rotate in and out. So we're still involved in the consultation. We can see and hear everything that's happening. We're just not sitting in the room with the patient at the time. But when it comes, say, for example, when it's my turn to sort of do my assessment and discussion, then I'll sort of rotate with Peter Martin or with Kate or Meg, our dietitian and our nurse, and then I'll be the one in the room with the patient. So kind of a bit of a hybrid model. Additionally, we still are doing some online exercises. We have one lady who we I do one-on-one exercise sessions with her, and then Bonnie follows up after that and does a little mindfulness group with her and a few other patients. We also use it for sort of ongoing monitoring of some patients. So it's being used, but it wasn't obviously not being as used as much as it was in the peak of the pandemic.
Yeah, I think we've certainly found ways to use telehealth that we'd never thought of before. I think all of those things that weren't previously part of our normal practice, but are something we can add now, and particularly good for monitoring some of those low and stable patients. But, yeah. So does telehealth work for everyone? Well, yes and no. Essentially, if we look and think about, the right person, right place, right time, the right person, the patient themselves needs to have the right tech skills and willingness to use them, or at least willingness to learn some more things. Sometimes they can have a family member in the house that can help them, but someone needs to have the tech skills. And the clinician themselves also needs to have the tech skills and the willingness. I know I certainly had to upskill a little bit, and some of us in PALCare are more and less willing to use it, I think. Right place is also something to consider. So you need the right environment, both for the clinician and for the person at home. You need a place that's going to be quiet enough for it, a place that's going to be confidential, and you need to have a device to use. And then the right time, like, we were saying earlier, if someone is in the later phases of the journey with palliative care, we really need to be going out there and doing a face-to-face visit, or if someone is at really high risk, we need to go out there. But it's, really appropriate for people if, they're low and stable, and if it's, fitting all of those things that we mentioned earlier. The other thing about time is that this time during a pandemic was the best time to start looking at telehealth for us, because people were really open to it. They were using it to chat to their families. They were using it for their GP appointments. They were using it in all different ways. So when we mentioned it to them, they were like, oh yeah, I've already done that last week for an appointment, or I've heard of it. So it was much easier to actually start it with them. The only thing was we did notice a little bit of fatigue around, screens with people, but mostly it really was the right time to start it. Yeah, that's mostly our presentation for today.
Yep, so thank you.
Yeah, thank you.
Thank you so much, Peter and Jill and Matt and Bonnie, and they have just proven that hybrid presenters can also occur. So we had two very efficient and professional people that weren't actually here, and two people that were here, and it worked. It actually brought back some memories. When the pandemic first started, I was called to a family of one of my palliative care patients, and they were in the terminal phases, and they were actually admitted to palliative care in home. So that means, for those of you who don't know, that they were like a hospital patient, but they were being managed at home, and the palliative care services had 24/7 people available to them to look after them. But the patient had become unconscious, and the daughter had contacted me, and this was at a time when the health professionals were probably more fearful than the public, who didn't quite understand the potential of what was happening. And I turned up in a mask and was very socially distancing, and I thought I was walking into the patient and his daughter and another person. And there were about 15 people there, and they were all drinking and eating and having a wonderful time, sending off this person that they loved. And the palliative care nurse and I were the only ones that were aware of wearing a mask and trying to keep safe, and understanding, though, that this family required this contact and interaction to farewell their loved one. And at the end of it, I was hugged by about 12 people. I walked out the door thinking, oh my God, and this is before we knew very much about it, and it was just still that anxiety. So one of the things that I guess I have worried about during the pandemic with palliative care patients is the existential issues that the families and the patients are trying to deal with, and the decreased personal contact that they've been able to have, but how telehealth has actually, to some degree, overcome that, in that you can talk to a person and see them sometimes on a screen. And so it's certainly introduced us to a new technology. Have we got any questions?
There are, but did you want to bring the panel back to?
Oh, yes. So maybe the panel...
Or did you want to make that a...
No, yeah, okay.
Okay, I'll just show you this one. So please do put questions in the live Q&A or using the app. I just wanted to see if you think this one's been answered.
Yeah, so... Whoops, Daisy. So question is, would you see telehealth contributing to patients who have a palliative diagnosis but are recuperating or undergoing some rehab at home after a severe illness or deconditioning, e.g. a prolonged hospital admission? So maybe Matt and Bonnie, you might be better at answering that than...
Yes, the caveats we have with the biggest concern we have with telehealth with patients we haven't met is around safety. So it's just around how can we safely set up an exercise program for someone who we've never met. We don't know what their mobility is like and their sort of functional ability. So that's where we, obviously, if someone is at home, they have good family members, ideally there's a couple of people around, so you can have someone holding the iPad and watching the patient as they're walking away, so we get a bit of an idea of how they are. But you can definitely set up programs. At minimum, we can set up a seated or bed-based exercise program to monitor it as we go.
Yeah, and we would commonly, if we can, go out and do the initial visit face-to-face and then follow up after that with telehealth. We have a lot of people who do that.
Got a question. Is my phone working? About, thank you. How would you overcome difficulty assessing an unstable patient on telehealth? For example, if Lily, the case that was presented at the beginning, had worsening neurology and headaches, how would you get around not being able to perform a neurological examination to determine the best course of action? Did you feel that too?
Oh, I might field this one to Peter.
We need to mic at the microphone.
Or Jill.
For you.
Jill, you're just as experienced, yeah.
We were still visiting patients, and obviously if people were reporting a change, a new symptom, something dire, we would visit. We were still functioning as a team. We were just trying to limit the number of contacts if patients were stable and well. Yeah. So we would have gone.
I'm going to break the rules and ask if anyone in the room has a question, because I know you aren't all able to access the questions on the app. Yes, Simon.
Come up to the stage so that we can hear your response. Yeah, sorry, you might need a microphone for Warrnambool to be able to hear you.
Very good. Just wondering if there's any services for patients who aren't on the phone, not really wanting to engage in services but are dying at home. So no family, no contacts, no friends, just living by themselves in a squalor.
That's where their GP comes into it. Yeah. And just because we have specialist palliative care services in our region doesn't mean that GP doesn't play a really important role in managing that palliative patient. So if the GP can identify their social isolation or gaps in their care, then that's where we can come into it. And I mean, just because we were anyway, trying to minimise face-to-face contact doesn't mean it still can't exist. And I certainly didn't stop doing home visits during COVID because of COVID. I think you have to assess and prioritise, but it still has to happen at times. But if any of our panel can, yes, Claire, go for it.
Sorry, I'll try not to hog the spotlight when it's not actually our turn, but when we talk about someone having no one, my ears come up, my spidey sense tingles, because sometimes people very rarely people have no one. They have some form in their community, but it's connecting to those people. So I think you probably had Kevin Lee speaking before about social prescribing and social connectedness, and we know it's one of the biggest determiners of morbidity and mortality when people are disconnected. And then we had 2 years of COVID, so everyone got disconnected. But we have beautiful community groups who are safe, able to engage, able to support. We have beautiful compassionate community organisations on the Ballerine, in Geelong, in Ballarat, and who can work wider. We have a great hospice organisation in Warrnambool, because I know they're online, and they're beautiful as well to do these sort of supports. We had we'll call him a collector, who had to move house in the middle of COVID, and I have never moved so many boxes in my life. And I found some amazing things and discovered to get rid of my sense of smell that Vicks is wonderful. And there are things that can be done by the community. It's a matter of putting it out there and asking, because I think the GPs are vital, and nothing works without our specialist palliative care, our GPs working together with the civic community as well. We can't put it all on the GPs. So I will expand later, I'll shut up, but compassionate communities can be a support for you as well when you're copping the whole load.
Yes, thank you. Anne.
A comment first. I think the palliative care unit and team have done a lot better than the other services at Geelong Hospital. So congratulations. Given that we're trying to learn from this pandemic, and this is to all of you, do you see a role of when patients are admitted to the palliative care team and the GPs involved, the first thing that's done is to provide them and educate them with video conferencing in their homes in case this happens again, because one of the things that happened was when the pandemic hit, you couldn't get any video conferencing supplies because they all flew out the door. So is there a role to actually make this almost a provision that patients are supplied with these things in case this happens again?
Anyone?
Yeah, and I think that's a great idea. Well, that's what I was going to say. The problem will be who will pay for it. I also think probably the work we did in 2020, I think there's a much more pragmatic approach to how we manage the pandemic now, where in 2020, it really was, patients were very isolated because there was a real edict to not visit people at home unless there was an absolute necessity. Whereas I think now that has changed, and now that's not to say there won't be another event at some point in the future, and there almost certainly will, but I think the way we're managing it now will be different. I agree. I think it would be lovely if that was the case, if there could be an iPad provided to people at admission, but the issue, like with most things, is who would pay for it. Certainly the state government have put more money broadly into home-based care, with an emphasis on the idea that most people do want to be at home, and perhaps there's some avenues there. But I agree, it's a totally great idea, but I think the issue will be who's going to cough up the cash.
Oh, sorry, one sec, sorry. So I do love live and interactive discussion. However, in order for Warrnambool to hear us, you need this.
On the financial side, most patients have themselves, even the elderly, or one of their relatives, an iPhone. And it's more a matter of just showing them how to use it and send them home with the understanding of how to use it rather than having to supply the device.
Thanks. And I think as our colleagues were presenting a service redesign, it's like we've all been through this process of designing, everything, redesigning everything we do, questioning patient flow, interfaces, integration. Has there been a massive design challenge? And I wonder, going forward, who's going to take on some of the challenge of actually looking at, well, in whatever comes up, whatever, crisis is upon us, how do we design that pivot and that ensuring that services aren't interrupted? I think that's the big thing that you're all describing, weren't you, that services were interrupted, and with this group that actually was very important that they weren't interrupted. I don't have any more questions coming through in the chat, so do keep active. We've got a few more minutes to Would you like to keep moving? Yeah.
Okay. Just
Well,
one more question.
Michael did put his hand up, so I'll go. Oh, sorry. There's no cables online, is there, to trip?
Thanks, everyone. Thanks for a great presentation. There may be an opportunity for clinicians, specialists to talk to the patients in the GP's room where everyone could be in that round table conversation. So, I mean, I think telehealth does provide that opportunity as well, where particularly when they're more remote and they could be sitting in with their GP and having a specialist consultation then as well. Thanks.
Thank you, Michael. Okay, we're going to move on to our second presentation, which is from Dr. David Brumley. David is a GP originally who developed a special interest in palliative care and, long story short, became the Director of Palliative Care at Ballarat Health Services and then the Medical Director of Ballarat Hospice Care, a position which he still retains in his semi-retirement. Perhaps what stood out to me in David's bio were his special interests, which were listed as number 1, GP specialist palliative care relationships, 2, doctor-patient communication, and 3, doctor self-care in the care of the dying. All really potently relevant. So, without further ado, David.
Righto. So, how does one work this? A big one. Okay. Well, thanks for that lovely introduction, Deb. I think those 3 issues are kind of important, and particularly, I think some of the things about the changes in general practice and changes in palliative care, if anything, are making it more difficult for us to communicate quickly and effectively between the 2 areas. And I can see all the things that are doing it and causing it, but I'm not sure I can suggest too many obvious changes. But today my remit was to talk about a patient, and this patient, Mrs. Julie, is actually a mishmash of a couple of patients, and to that extent some of the background things have been mixed together. But in any case, Julie is a young 70-year-old retired secondary teacher living with her husband Miles, who's in good health. She's living in a semi-rural area, and for those of us living on the Bellarine, it's nice to know that some areas around Ballarat are still actually rural or semi-rural. She was a very keen volunteer, a very community-minded person, and had been in generally pretty good health apart from mild asthma. And so they together had 2 sons, 48 and 46 now, each with their own families and living both in Melbourne. She had breast cancer, and the presentation was 5 or 6 months ago, and presented actually with symptoms from the secondaries rather than the primary, in other words with a cough, shortness of breath and some vague and generalised chest discomfort. The examination at that time showed her quite thin. She had lost a bit of weight and tired and unwell, and certainly felt unwell. And the only thing examination-wise that was obvious at the time was a fairly easily palpable mass in her right breast. Which does bring me to one comment about telemedicine. It's hard to find breast masses on a tele visit, and it has resulted in a substantial reduction in the diagnosis of cancer in the community in general. Anyway, she went ahead and had the usual investigations. Both mammogram and ultrasound were concordant and showed a lateral mass of 2.5 centimetres in the breast. But sadly, the PET scan she had rapidly after referral to her oncologist showed very big right para-aortic mass, right pleural effusion, lots of mets in both lungs, multiple masses in all lobes of her liver, and multiple masses also in her axial skeleton in thoracic and lumbar spines, and her right adrenal gland. And not surprisingly, the biopsy was positive. So she went on in the usual way to have fairly urgent commencement of chemotherapy and shortly afterwards immunotherapy. And it was about a month ago in the course of events, in other words, about 4 months into her treatment, that she received her a referral to community palliative care. And that was perhaps a question I could get Claire to comment on. Do you think the timing of that referral was reasonable from a GP perspective, Claire?
With my bias? No.
Okay.
Sorry, I would have liked it earlier, but that's my bias.
Would you agree generally that it was perhaps a bit delayed? It would have been a reasonable referral right at the outset, because truthfully, it's pretty unlikely that this woman is going to survive this disease, isn't it? Despite the fact that treatment may slow the progress of the disease substantially, it's unlikely that she's going to be fixed. In any case, the community palliative care service did what it often does. They encouraged her to reflect on her disease and supported her and talked about her existential problems. They also converted that existential discussion into a real discussion about what she actually thought she might want and not want in terms of medical type care. In that she completed an advanced care directive. She was unable to engage in any discussion about end-of-life choices, really. She put some generalised ones on the Advanced Care Directive, were the usual things like, if there's no prospect of recurrence of return to a normal state, I don't want to be treated, etc. But sometimes they degenerate into a kind of fluffy dream world rather than a clear and explicit request, and so it was with hers. She indicated, though, very firmly that she wanted no further aggressive interventions, no intensive care admission under any circumstances, and above all, to remain at home. She was strongly supported by that, by her husband particularly, but also by her extended family of kids. So we now jump in time. Have I missed a slide there? No. To about a week ago, when the rapid progress of her disease was evident, with ongoing, quite very severe loss of weight, and she's now bedbound and quite weak. In the last 3 days, she's experienced increased and quite severe right upper abdominal pain. She's unable to sleep because of it. She's aware of breathlessness all the time and has some ongoing cough. She has, according to her husband, some quite mild delirium, fluctuating from pretty much nothing to mild delirium and confusion. And her husband thought quite rightly that she was a little bit jaundiced as well. The breast cancer, the medication at this time was pretty much as expected, I guess. Arimidex, paracetamol for pain. She'd also been taking some Targen tablets, the 30 milligram strength, and some Coloxyl and Senna, some breakthrough dosing of oxycodone, in other words, endone, and she was using a salbutamol inhaler to try and help her breathlessness and cough, although it wasn't, for obvious reasons, very effective. So I want to ask Claire what she thinks about, from a general practice perspective, about this current list of medications. Do you want to take it?
Sorry. Well, I would be thinking that Arimidex, paracetamol and Targen all need to disappear. We need to think about something other than Targen because of naloxone. We know that the liver's, well, we knew about that at diagnosis, didn't we, that there was an issue with the liver. Coloxyl and Senna, good, because the hand that prescribes the opiate should also prescribe the aperient, otherwise they're the ones that do the manual disimpaction. That's the rule. And I'm wondering about even, sorry, you just want to get rid of stuff? You want to add stuff? I don't know. I'm thinking that we could probably do better for her cough and her breathlessness and perhaps her anxiety, as well as doing something about her delirium. There might be some options there, but we could certainly simplify her medication burden and look at, honestly, some injectables. She's bedbound. We've got to look at what we're doing at home. She's in a semi-rural environment. She's got a supportive family. We want to keep her there.
You're too quick by half, Claire.
Sorry.
Well, my thoughts were, and if it was interactive and you were able to speak back to me immediately. You know, these were the questions that I had in mind to ask. You know, do we need to do any further investigation of her abdominal pain? Well,
we can also use.
well, how about we just stick your hands up if you agree?
Also, there's a discussion board for people at home. So for people at home, you can add your thoughts to these questions in the discussion box.
All right.
All right.
Okay, so just indicate with your hand if you think that we should take her to hospital and reinvestigate this current situation, reevaluate the level of attunement. No.
I've got some no's from the floor.
I think that was
here in
no's all
Geelong.
round,
Yep.
which I thoroughly agree with. Should we investigate the jaundice or the delirium? No?
No.
Do we need to alter any of the medications?
Yes.
Okay. Well, I think Claire's covered the ground there pretty effectively, and we'll jump to that in a minute. The other thing, of course, I think we need to do is to have some serious discussions with the family, because it's very unclear at this stage whether the family are fully aware of how sick she is, fully aware of what's likely to happen and in what time frame. So there's a lot of quiet chat required over the kitchen table about all these matters. She may also need a hospital bed to keep her comfort, and other aids, of course. So here's my little reply to all these questions. We agree that she doesn't need any further investigation of the abdominal pain, which is probably hepatic in origin, though we can't be sure. We probably don't need to chase the jaundice because we have an underlying explanation of that. We do need, I think, to alter the medications, and I agree with what Claire has suggested, that the issue of targin in liver failure is pretty clear now, I think, in that the naloxone part of targin needs to be chopped up pretty completely on first pass hepatic metabolism in order not to be present in the peripheral circulation and interfere with the analgesic effects of the oxycodone. So it makes a lot of sense to stop the targin and to just use oxycodone alone. It's very common for us in practice to see the combination of targin and coloxolin center, or targin and other aperients, which strikes me as an indication that the targin doesn't seem to be as effective as it might be in managing the constipation anyway. I'd also say that we very often see remarkable improvements in pain control when we swap people from targin to oxycodone without naloxone. And it's, I think, sometimes sensible, perhaps occasionally, to do some dose reduction in the dose of oxycodone, depending on the circumstances of the patient, obviously. Do you think there's an issue there, Peter?
No, I do.
Yeah.
Sorry.
Sorry.
Yes. No.
Yes.
No, I totally agree, David. I think targin does have a role, but the company are fairly clear that it's contraindicated in moderate to severe hepatic dysfunction, and should be used with caution in mild hepatic dysfunction. And I think you highlight a problem. I think sometimes we probably do see people becoming perhaps opioid toxic or more opioid toxic when they're rotated from targin to an equivalent dose of OxyContin, probably because they've been getting a relatively lower dose because the naloxone has been antagonising some of the oxycodone.
Yeah.
And as you say, though, it's very contextual. If someone's in the last days of their life, then that's not so much of a concern as someone who might be in a clinic and able to get around. So.
Yeah, quite. So there's a little bit of thinking required in making that swap, but certainly targin is better avoided at this point of the argument anyway. As Claire already said, I think we need to consider providing some injectable drugs, and the discussions with the family, the plans for dying, the medications for the management of the dying phase, The teaching of the family, I mean, I reckon almost all of this in our terms is about teaching the family and providing them with as much independence from us as we possibly can. I think philosophically that's a really logical thing to do, regardless of anything else. You know, I think the difference between good medicine and rat bags is the degree to which they create ongoing dependence, frankly. And I think it's our job to try and give this family who clearly want to do this at home and want to be independent, to do so with our support. So we've talked about that. So the night before, family gathering because she's deteriorating and looks as if she's going to die soon. Quite distressed, had some morphine subcutaneously, which settled her for the predictable 4 hours. But to chuck a problem into the mix, her husband thought he better do a RATS test to make sure that she didn't have COVID-19 in addition, and of course it came up positive. He did the test on her. He subsequently, of course, everybody at home rushed out and bought some more from the local chemist and did one, and they're all negative apart from her. So it was never clear where the infection came from, actually. So what to do now? Should we refer the patient for inpatient care in a hospice? Should ring up Peter and Jill and ask them to take her in, or do we keep her at home, in which case how do we manage? Well, in fact, it was repeated and was persistently positive. They really did want to make sure, and so did I, that it wasn't. Should we have found a pathology lab that was prepared to come out and do it there? I didn't think it was even worth asking, frankly. Anyway, where were we? So in response to the positive RATS test, we needed to assume that it was a true positive. It certainly looked that way, and the repeat was just as positive. And I understand that the false positive rate for these RAT tests is somewhat low, and the usual issue is around false negatives rather than false positives. So we talked about what to do, and we talked about the fact that all the family members and anyone else who'd been there for more than a little while in the house was a close contact, and they had to treat themselves as such. They were happy to be isolated in most ways anyway. We considered the origin of the infection and really never found a suitable answer. The family reiterated their wish that she stay at home. So this then created the problem of, is it possible to provide, 24-hour medical and nursing support and other supports to this family in order to allow them to do that? It clearly didn't look like a long time, but it could be quite intensive. So we talked about transferring her medications to injectable form and to adjusting the opioids to her needs, and perhaps also using some mild sedative or something like that. The question of oxygen was raised, and our understanding in our last contact with the providers was that they were not happy to provide oxygen concentrators because of the potential for a spread between patients. So the problems were traditional syringe drivers were not, quote, advisable. Oxygen concentrators were not advisable. We needed to check with the palliative care service, and fortunately they were willing to continue their care, although they explained that they needed to reduce their exposure as much as possible. So we thought that family involvement in the basic care was essential, including the capacity to provide medication, not just the background medication, but also the provision for extra doses of morphine, of opioid and of sedatives and other things, as I'll get to in a sec. I was also heard, although it never became an issue, that some other services like the Commonwealth Home Support Program just were not necessarily able to continue care at home, and we might have to work without their ongoing support. Now the question is, what drugs did we think were necessary? And really these are the 4 that we would always be ringing the general practice to ask for. in adequate doses to manage for weekends and nights, and enough for breakthrough, and enough to reduce the anxiety on the part of the family and stop them running, or one member of the family running in and out of the house to the chemist every day. So whatever opioid we chose to use, I think morphine would be the most usual. Some metoclopramide or other antiemetics such as haloperidol, but usually metoclopramide. Some midazolam as a sedative, and some buscopan for the rattles of terminal bronchopneumonia, if you like. And I just would point out that it's really helpful if we do the calculations and make sure that you've got enough of everything, including sometimes the need to ring the Commonwealth to get approvals for larger quantities. Metoclopramide, for example, you know, if you're going to give 40 milligrams a day in a continuous infusion, it means you do your maths and you're looking for 30 plus ampoules per week to carry on. Some people feel that ordinary syringe drivers like this Nicky pump are not suitable for use with COVID patients. I don't know that that's the case, whoops, but it's certainly some providers, some palliative care community providers prefer not to use them. And the plan we have in Ballarat is to use this particular one as an alternative called a Sure Fuser. It's expensive, it costs about $30 a pop. It's single use. You have to dilute everything you put in it to 50 mils because it's organised that way. You can buy different tubing rates from 12, 24, 48 hours, and that is controlled by that little bit of blue plastic on the tubing itself. But those who've used them have found that they're actually pretty effective, and certainly if they became more commonly used, they would probably drop in price. But that was an alternative that we chose to use in this patient for a couple of reasons. Firstly, the nurses wanted to reduce their visits as much as they could, and the 48-hour infusion option was a useful thing in that context. This is a little bit of how legible it is for you. You can probably see there, but it's just to point out that the nurses who were going to the house and getting all dressed up in their PPE, including having been fit tested and using the N95 mask and all of it, was terribly costly in terms of time and effort, and it made the nursing and the talking to the patient very stressful for the nurses and the doctors too, but particularly the nurses who were doing things like turning her over in a bed and that kind of thing. Very, very difficult. So it's not an easy matter. The other question was raised whether the family would want to leave the house or anything like that, and they chose to stay put really and to get others to do any collections and food for them. So the whole house essentially became closed to outsiders. So there is there are a lot of documents around on the subject of managing COVID patients at home. This is one such document that you can access from Grampians Regional Palliative Care Team and Western Health, which just sets out some basic things. And the only thing is to add is that she died comfortably on an infusion of about 60 milligrams of morphine subcutaneously per 24 hours. With some metoclopramide, I think 40 milligrams each day, and with some midazolam to settle her agitation and anxiety from memory, I think about 45 milligrams, 50 milligrams a day, which is a relatively high dose perhaps. But her comfort was fine. She didn't have any further trouble, and the presumably liver pain was settled pretty well in that regard too. But then we came out to the issue of when she died, what we should do about her transfer to the undertaker. They were pretty anxious about it, and they gave us this little list of things that they expected of us. That we had to put the body in a bag, or preferably double bagged, that the body had to be labelled appropriately so everyone could run away if they felt the need. And the funeral directors who were required they expected them to wear PPE at all times, which I guess is reasonable. and that embalming, although it's pretty rare in Australia anyway, was clearly not a good idea, being quite invasive and high risk. Okay, well, I might hand it over to you, Claire, and just get some comments from what I said, if you will.
I don't think I need to in the 1 minute that I've got left. It's beautiful. It's wonderful that they were able to be at home. My spidey sense, again, went off right at the start when we were talking about she's an active volunteer, engaged community member, and I'm thinking back then when we get this diagnosis, that's probably when the GPs in this room and online are probably sitting down with her and saying, gather your crew. This is the time to get the people around you that you're going to need to support you, to support your husband, so that there is that sort of inner circle, you know, so we talk about the outer circle, the people you're okay with borrowing 20 bucks from, then the inner circle that you're okay seeing you naked, you know, think about that. So she's got her inner circle there, and you've got your outer circle, you've got the people who can do the shopping and bring it to the door, who can pick up the scripts when, you know, I've mucked up the calculations and we actually need more midazolam, and use Proda. Don't sit on the phone, use Proda a lot quicker. And then we go and have that support for them there for when they're out of isolation, that they're there for the family. And I think things like changing pads, rolling, although rolling's a whole other argument that I have about pressure care, but anyway, I won't get into that. And administration of medications, I think, is all something that can be thought about early. Sometimes you can't get in. You can't get in with the family, and that's not going to be discussed. But she was very firm about being at home. So I wonder if part of that is, okay, you're very keen to be at home. These are the sort of things that might help you. And then that also helps the palliative care team. And these poor nurses who are going out and getting dehydrated and rugged up all over are supported as well, because they know that the personal care of the person is being done as well.
Thanks, Claire. Thank you all.
Double thank you. We've got time for any questions?
No, I don't think we do. I just wanted to check, Rod. Yeah, as I say, the question about the syringe driver, did you feel that was answered? Yeah, great. Okay, that's it. And we'll...
The reason why you can't use them is the company doesn't want it being used and wasted.
Yep. Okay, cool. And then there are still, please do keep putting questions in the chat. We'll hold them for our panel discussion at the end.
Great. Thank you very much. Now, I'm now supposed to introduce Claire. You've already met her about half a dozen times already today. But as a proper introduction, Claire is a GP in Central and Regional Victoria who had the advantage of the perfect role model, a father who was a GP in a rural area who for 43 years cared for his patients from cradle to grave and beyond. So that's the role model she's been brought up with. You can understand now why she's so passionate about her patients. Claire's passion is to assist patients understanding their options of care and involving them in decision making. She co-founded Shannon's Bridge with Jeremy McKnight, which is an organisation I'm going to let them elaborate on because I would never be able to give it the justice it deserves. And before I open it up to Jeremy and Claire, I have to go Jeremy's now. Jeremy is not by training a health professional, but in my mind is one of those people who has turned into a health professional by supporting those in need and therefore making a difference to their health. His introduction into the palliative care system came when his 17-year-old daughter was diagnosed with a disease that resulted in her passing at the age of 19. However, what was an obvious tragedy has resulted in the creation of an organisation called Shannon's Bridge, and as mentioned previously, I'm going to let Claire and Jeremy tell you more about that. Thank you.
Thank you very much for the introduction and for allowing us to be here today. I realise it's been a long day, so I'll try not to keep you too long. As far as the introduction to Shannon's Bridge, maybe a small background as to why it all came about. And this is obviously just our experience. We realise that there are lots of experiences and everyone feels different things. But as far as ours go, yes, Shannon, very active teenager. I was very, very lucky to have a good relationship with her, which is unusual for a father and daughter. She was diagnosed with a very rare form of leukaemia, which led to a year of being in hospital in Sydney for highly experimental treatment, resulting in all sorts of experimental chemos, radiation, and finally a bone marrow transplant from myself, which was quite rare. Unfortunately, that didn't take, and she then had to have a second year straight in hospital in Royal Melbourne for more experimental treatment. During that time, as I think many people do, you're very grateful for all the help you receive from the nurses and the doctors in hospitals who bend and break rules to make sure that Shannon's comfortable and that I was comfortable. But we also looked around to see what we could do to give back. And many times I realised that it was the people around us who were going through a lot themselves who were actually giving us the most support. Shannon was coded once and was paddled, and 12 doctors standing around telling me that she was going to die, and I collapsed. I started crying. And a mum from the ward came up and put her hands around me, and I had never met her before, and just held me like a mum and stayed with me for the next 2 hours until Shannon went to ICU. Her husband died 4 days later on the ward, but it made Shannon and I realise that there's a lot that can actually be done here just from people willing to help and willing to be there for someone. As Shannon's treatment and illness advanced, so did all of the symptoms that came with it. So Shannon, because of the intensive radiation, gradually lost her eyesight and also just the shape of her face. And one of the last things she said to me was, "I don't even look like a girl anymore. I'm not even pretty." So it was hitting her quite hard. Towards the end of the 2 years, that was 2 years straight she had in hospital, we were given the news that there was nothing further. And where did she want to be when she was going to die? Shannon said, "Home. I just haven't been home in 2 years. I want to be in my bed, use my toilet, have my coffee cup." So I took her home. I didn't know how much time I had with her. At that stage, I knew her medical treatment inside out, back to front. We'd make bets on what her stats were each day and laugh about the fact that we got it right and the nurses got it wrong. But on saying that, things were changing incredibly. And as I said, Shannon was completely reliant on me being blind. And I just quickly realised that where we were, which was based just outside of Talbot, we were on the border of about 3 different healthcare services, none of which were available to us after hours, and none of which were available to us after 5 o'clock at night. So it became very scary very quickly for me as far as if something happens, what do I do here? The second day Shannon was home, she had an episode, she had a bleed into her spine. And I was very fortunate that Claire came and sat with Shannon and myself and went through some of the things that could possibly help over the next couple of days, and certainly helped Shannon that day. And I was being a typical male. I rang her the next day and said, "I didn't hear any of that. Can you please come back and tell me again?" Which she did. And in saying so, in doing so, she was very kind and left me with the forerunner to the Shannon's pack, which is basically an emergency symptom relief pack. It doesn't, thank you, Sarah Senfrigel, doesn't actually, it's not designed to replace any medical care at all. It's basically, it is a Band-Aid full of things, mouth care, all sorts of different environments that go through, or things that can actually help the nurse or a doctor in that environment, but it'll also assist the family if that person would like to be at home. So over the next 3 days, I used it another 3 times, which allowed me to keep Shannon at home. Otherwise, she would have died in hospital. And the night before she died, she said, I'm comfortable and I love you and I'm so glad I decided to stay at home, but I need you to do this. I need you to help other people anywhere, anytime. That's what I need you to do. It was a very easy promise to make. So she died in my arms later that night. And it was about a week later that I met with Claire and said, what do we do? What do we do here? My background is as a firefighter prior to this. So my only experience was with Shannon. And we decided to try and do some fundraising to get some of these packs in some local GP surgeries. Claire thought that might be handy. So we did that. We quickly raised money for 4, 10, 30, 100, 1,000, 1,500. So we put them all at Australia. It just got bigger and bigger. The more that we were talking to different organisations, and we'd talking at the opening of a fridge, it was, we were doing a lot of talks, and pre-COVID. We quickly realised that the general understanding of what palliative care is in the community was limited. So explaining the basics to every group, but also hearing the experiences of the people who were going through or had been through something themselves was beautiful for me, because it taught me more. And it also, in many cases, allowed people to talk about things because I was talking about Shannon as well too. So many men's clubs and men's sheds, things like that, allowed us to talk there as well too, because traditionally men are horrible at discussing things and talking about loving your wife and loving your daughter and holding their hand and things like that. So it opened up a lot of doors that way, which is great. But it also raised their awareness to the fact that we needed to do more. This is a Band-Aid. This is good. It's nowhere near enough. And anyone that had been a carer before or has seen carers in action realise that it's a 24-hour-a-day job, and everything else that your world just stops as you're a carer. Nothing else normal happens because your whole soul goes into that person. So we need to try and figure out how to support the carers in this role, the person themselves, but the actual carers as well too. So we looked into becoming an actual charity and business and ACNC and DGR and all the sexy letters, and got all that done. And we spoke to 11 insurance companies, 10 of which hung up on me as soon as I said community palliative care. So as soon as I said that's not medical, you guys are not going to do right thing, you're going to do dangerous things and we don't want to know you. So it took us about 18 months to actually get everything up and running, and that included meeting ISO standards, WorkSafe standards as far as safe working practices in the home for volunteers as well too. We put that all into place and it was working quite fine, and the volunteers were actually coming in and we expanded our services across vast areas all through Victoria, through Australia as well too. And in doing so, it was wonderful. We thought, what do we actually need here as far as a volunteer goes? We need someone who can transport, someone who can cook, maybe someone who can possibly sit with someone. We had that in the first person that volunteered for us. But what we realised is that people were coming in with so many more skill sets that I didn't realise. We had a lady who said, I hate people. I hate people. I don't like being around them, but I love animals. What can I do? And I said, we're in the country environment. This is fantastic. So that lady helps us. She goes out to the farm and stays with the animals and helps us with the stock, allows X to come in and go to his treatments. So everyone had a need there, and we were also finding people with backgrounds such as, music therapy, art therapy, pet therapy, that were also coming in as well too. In doing so, we met with a lot of healthcare services around the area just to say, how does this work? I'm not judging, I'm just saying, how does this work? How's your volunteer situation work? And I found that it was very, very common to underrate the value of a volunteer in this area, to the point that we had services tell us that they had their volunteers not make eye contact with their patients because they weren't trained to do so. They could actually sit with a palliative care patient for no longer than 20 minutes because, again, they weren't qualified to do so. Things like that. Surprisingly enough, there are the same health services that had an 80% turnover rate in their volunteer programs that lasted approximately a year to actually train someone to be compassionate. The majority of our volunteers are people who have been through something themselves and have experienced something themselves, and their experience is something I put or highly value over anyone else. Funnily enough, our turnover rate for volunteers is 0 because we try and value the people in their environment. And as far as the growth of the organisation, it boomed. And we started to train other organisations, and everything that we had as far as all our policies, procedures, guidelines, whoopsies that we made, of which there was a lot, was available to every single organisation that we spoke to say, here you go, have at it. Don't worry about setting everything up yourself. This is everything you need. Take our name off, put your name on. Everything we do is for free. There's enough palliative care to go around. So that quickly grew. I think we've currently assisted about 60 different organisations to do what we do in various forms and shapes. Part of that has been the equipment usage, which we basically we fundraised for a bed and a wheelchair, which went out very quickly, and then started working very luckily with some organisations, large hospitals and aged care facilities who, because of internal policies, at the end of 12 months, they throw their high-low beds out, they throw their hoists out, their over-toilet chairs, wheelchairs. So if it's 12 months old, goes to the tip. So, and that wasn't one organisation, this is across the board. So we spoke to everyone and said, no worries, we'll take all of that. So what started with us keeping it in our lounge room grew to a warehouse that we now have fundraised for with a truck, and we've got some volunteers that help us get that equipment throughout Victoria, throughout Australia, throughout the world. So we're actually working with Rotary as well too about shipping equipment everywhere throughout the world, including at the moment trying to get some stuff over to Ukraine. So it's expanded far beyond what we thought it was. But in doing so, again, it's a huge learning curve for us to see that, speaking again to a lot of the health organisations, what the volunteers, the list of things that the volunteers were not able to do was 3 times the size of what the volunteers were actually able to do. And that was also conversed their turnover rate as well too. And speaking to a lot of volunteers, I don't feel valued. They don't let me do what I'd like to do. So we realised quickly that the compassionate communities approach, which I'll let Claire explain to you more, was the road to go. And because of that, it's opened up a lot more doors for us and allowed us to spread our knowledge and mistakes throughout a wider variety of organisations who are already doing this. The Rotaries, the Lions, the CWAs, the school groups are already doing this. And it's a confidence issue with them to see that they can actually be involved in home care for palliative care. COVID hit, as it did with everyone. And instantly, in that sort of month period, especially with the phase 1 to phase 2, the need for our services increased tenfold, as we found that there was a lot of uncertainty across the services as far as what to do, what should I, can I, can't I do. And so we were getting a lot of calls from areas that people were not going out due to the services being unsure, and also equipment not going out. So our services went through the roof. So we quickly realised that there has to be something that can be done here as well too. The service was doing a wonderful job, but this was unknown to everyone. So what do we do? So we went straight to WorkSafe and said, what can we do here? How can we have volunteers work in a COVID-safe environment, COVID-positive safe environment? We had policies and procedures drawn up and got those out to other organisations. And then we put it out to our volunteers and we thought, if we can get 5 volunteers, that would be really good. Yeah, 1 would be great. We got 50 overnight that straight away put up their hands and said, we're willing to help. What do you want us to do? So our volunteers now operate in COVID positive environment, have since phase 1, HIV positive environments, work with the prisons, work with homeless palliative care, which we do a lot with as well too. So underestimating what a volunteer can actually do. And as far as yesterday, I had someone say, we're very unprofessional. Volunteers can be unprofessional. And I thought, okay, thank you. So it's a confidence issue in seeing what can actually be done. And when you actually go to your community, family and anyone and just putting your hand up and saying, help, we need some help here, you would be amazed what comes out of the woodwork. So we're very fortunate to be where we are now, and the fact that our accountant hates us because we really don't have a business plan. It's literally, as opportunities arise, then we work with that. And if there's a need there, we fill it. So we are not a health service. We're very proud not to be a health service, but we fill gaps where we can. So going quite well. And I said, probably a long talk for the end of the day, so I'm very sorry. But I'll pass over to Claire to explain a little bit more about compassionate communities.
Always a tough act to follow, but this time we didn't have all the beautiful photos of Shannon, so I'm kept it together a little bit more now as well. So compassionate communities, you might have heard of compassionate cities, compassionate city charter, all this stuff. What does it actually mean? A compassionate community is one that knows and has the confidence to get the information they need to help people with end-of-life care. It's a death literate community. And what death literacy means is not that I know everything about woe to go with caring for someone and after death care. It's I know where to go and get that information. I know that funeral director can tell me about cooling blankets if someone wants to do a vigil at home. I know that I can talk to my local palliative care guys and say, gee, those Shaw infusers, that's 50 mils, that's a lot, even in 48 hours, you know, is that going to be okay for my patient, or what should we do? So a compassionate community is one that is engaged, all the wank words, engaged, involved, all that stuff, but moreover has the confidence and the skills, are given the skills to do what they need to do to care for their own, if someone's caring, dying or grieving. And we know that our systems and our services are just run off their feet and were before COVID. So of course, when the crisis hits, everyone steps up. And I'm talking to a room full of people who are at a weekend education when they've worked all week and probably half of you are on call. So I know I'm preaching to the converted here. But the point is, there are things that the community can do and did do through COVID to really increase the quality of end-of-life care for your community. So we had 98% of the 98% of the people that we looked after as Shannon's Bridge, not me as a GP, I think it was 100% me as a GP, but 98% as Shannon's Bridge were able to stay at home through COVID, through 2020, 21 and up till now for their terminal phase. If that's where they wanted to be, they were able to stay there. And that's because we were able to get the supports around there. Nobody can do this alone. We all need to work it together. The two that I don't know what her wish was, and another ended up in a dialysis situation and moved down to Melbourne, and she died there in the middle of phase 1. Everyone else has been able to stay at home. So a death literate community, a compassionate community, there are already, as I mentioned before when I stole the microphone, organisations like Compassionate Hearts on the Bellarine, Ankara, Barwon Health has a compassionate communities approach. There are things out there. All our resources are for free if you're interested in it, because you know what? These are the people, when you're sitting there going, this guy's falling through the cracks. He's got no one. He wants to die at home, but he's got no one. I'm not saying you can always do it, but it's amazing how many times things can happen so people can be where they need to be. I have learnt a lot more about changing pads, putting together hospital beds, all of the above than before in COVID, because I needed to. And now that makes me have more capacity and more ability to work in end-of-life care, because I get that. I've done more body preparation than I ever did before COVID. And I'm really fortunate and blessed and honoured to be able to be involved in that. That's my choice. There'll be a lot of people in the room who are thinking palliative care is the worst thing. I'd rather go to the dentist. I'm not keen on this, but I'm here. I want my points. I get that. But it is part of our role. You're seeing someone before, you're going to see their family afterwards. You need to be able to know a little bit more about this, and that's why you're here. Some of you will have been doing palliative care for a lot longer than I have, and so I'm not trying to teach you how to suck eggs. But the point is, groups like Shannon's Bridge, we're physically located in Creswick, which is just north of Ballarat, but we have the ability to support groups across Victoria. We actually do interstate, but we're not meant to tell the government that, are we? No, we just do Victoria. So if you're thinking, dang it, I'm not in that area, never fear. We have equipment, essential packs that we can give out to community groups that can, and also all the resources, all the health and safety of how to put it together and all that, free. $20,000 worth of equipment, free to a community group, so that then when your palliative care unit is overloaded and overrun on a Friday night and someone really needs a bed, bob down the roads, got a bed, got a trailer, got rails. It's not rocket science. Let's save our specialist palliative care guys and our beautiful GPs for the crunchy end medical stuff, not the running around and sitting on the phone to Medicare. Yeah? There's things that we can do to make your lives easier. Come and talk to us. shannonsbridge, all one word, .com. We do have a website. I'm not a web designer, so it's not that fancy, but the email details are on there as well. Please get in contact if we can help you. Normally I would hand around the Shannon's pack, but I realised that was probably a very nice fomite to go from table to table, so I thought I'd better not. But if you want to have a look at it, feel free to come up. I think that's all I needed to say. So thank you.
Thank you again, Jeremy and Claire. In fact, you can open that up, Claire, because at least it's pretty neat.
So it's got
I've used them before.
a happy customer. So it's got, I don't know whether I should be yelling. It's got a slide sheet. It's got vomit bags, mouth spray, lip balm, the plain mouth swab, so you can dip them in your beverage of choice, red wine, just saying. Tape for labelling the syringes. Butterflies. I couldn't believe my doctor's bag, no butterflies. I could intubate someone, you know, sort of, or bag them, but I couldn't put a butterfly in and give them subcut. They're about $6 each. There's a couple in here. Taps, water, drawing up syringes, sharps container, sharp opener, and a little box here, padded box that we put the amps in. So we post these out all around Australia with everything in them, except the medications. Thank you, Australia Post, we don't do that. And then the idea is that goes from the primary care physician, be that the GP, the bush nursing hospital, whoever's doing that 3 o'clock in the morning call, they assess what the person needs. And if they think they might need some extra amps, they can put them in the box there. I've left this at people's homes on top of the fridge. I said, have a look in it. It's yours. It's yours to have a look at and get comfortable with. And there's a little information booklet that goes along with it, with everything in there about bowel. Oh yeah, there's Movicol in there too. We love a bit of Movicol. About bowel care, mouth care, self-care, all of those things in there with emergency contact details on the back. That sat on the top of someone's fridge for a long time when it didn't need to be used, and that's good if it's not needed. But this is for the unrecognised palliative care patient, the one that hasn't been admitted to a palliative care service but decides 19-year-old lady, 11 o'clock on a Saturday night, I've got severe heart failure and I'm not going back to hospital again. Okay, well, we can't use oxygen. You can probably put it down, Deb, you get sore arms, sorry. You might not be able to use oxygen concentrators, but we can use fans. We can open the window. You know, there's things we can do, have the air movement and other things that we can do to make this person feel more comfortable. All right.
Excellent. So Jeremy's gone from being a firefighter to somebody that's putting out other sorts of fires. Yeah. Questions? Have we got any questions?
We do,
Yes.
yep. Okay, now Claire, this is for you. I know you did say that you had a spidey sense, but of course, how do people actually refer? You did describe it, but I think people would like to know about when's a good time to refer, at initial diagnosis, or when it's decided the person will be palliative, or some other time.
So refer to a palliative care...
To you.
Or to me. To Shannon's Bridge.
To Shannon's Bridge.
If you're thinking about it, give us a call. If you're thinking about it, that means the family are probably thinking about it, or you know something that you haven't quite told them yet. If you're thinking about it, do it. When someone's made palliative, I love that statement, big palliative stamp on their head. It's ridiculous. The point is, we don't tell this lady 5-6 months ago with her diagnosis that all the treatment you're having is palliative intent. None of it is curative. So we've got to start by being honest and then having a talk about it. We don't go in there guns blazing, and the most often the referrals that we get are, I'm not sure what this person needs. They want to talk about advanced care planning is the big one, and we do a lot of advanced care planning and going in and talking to people about that, or they just need a wheelchair. We take a wheelchair around. Guess what? The discussions happen at the gate, we all talk, things go from there, and then, okay, well, what else can we offer and what else do you need? And we don't like reinventing the wheel. If there's services out there that is doing this work, we're really excited and we'll be directing them back towards that. It's for the people who are falling through the gaps.
Thank you. Can I throw this around to the panel as well? And this will relate to one of the other questions that's coming. It's that how to create a seamless, consumer and patient-centred passage through this. So really from when a GP might, diagnose to Shannon's Bridge to the tertiary services. David, did you have anything you wanted to comment on that?
I'm just thinking about how it actually happens in practice. It's usually a GP referral to a community palliative care service, and then a nurse devoting a couple of hours to a conversation with the patient and the family, and then that nurse, in a sense, acting, as an organiser of the other services. So she would often be the person who contacted Shannon's Bridge or some other, or community huts on the Bellarine, that sort of additional agency to help with other things. So the community palliative care service would normally also, if it didn't have its own physicians, palliative care physicians, ask one to visit, as that's the way it happens in Ballarat. Here, I think it's much it's better organised in that sense. Yeah. So I think the answer is the way it is at the moment. That's the way it is, but there probably is a better way. I think a central coordinating agency might, at the risk of further, complexity, be able to do as well or better.
Did you want to make comment on that process? No? Okay, thank you. So this is a reflection, but is followed by a question. So it's a reflection about from this practitioner, the worst experience of their medical career was a dying patient who did want his wife to promise to keep him at home. And it was, really the impression was that it was 3 months of unreasonable suffering for the wife. David, this came up through your presentation, but I think this could be really anyone on the panel to address it. But how do you deal with these cases?
Well, it's an unwise thing to promise, isn't it? Because it's a promise that can't be necessarily fulfilled. And as part of the discussion you might have with this woman is that there comes often a time when it's just too hard, no matter for any human being to do. And that's the kind of phrase I've just used. I respect the fact that you've done an extraordinary, almost superhuman job of caring for this person you love to bits, but it's got to this point where I think a short-term admission to control this symptom or a longer-term admission for end-of-life care just seems to me to be the way to keep him more comfortable. So I'd couch it in those terms, I suppose, the issue of comfort for the patient, the acknowledgement of a job well done to the carer, and hopefully, well, most of the time, that does the trick, I think. But there is occasionally a problem, isn't there, with people who don't see the wood for the trees and for whom a battle can happen between a relative who just doesn't agree to what we might think are reasonable pain control measures. And I mean, I've never seen it work to go in with guns firing. I think the way to do that is to maintain the relationship and work as quickly as you can to balance things. I'd be interested to see what others think.
And Jeremy, I'm just thinking, this is really thinking about end of life for the patient, but what about the carer, as you described? Have you got any feedback from, from carers about end of life decision making, advanced care planning, and goals of care, and whether that's inclusive of carer wishes?
Yeah, very much so. I mean, a lot of what we do, and I think a lot of how we are responsible for the community is, as Claire said, people are coming in asking for advanced care plans, or just to find out about this, or Dad's just got a diagnosis. What happens? It's essential to look at things early, but we realise that some people aren't at that stage. They might be thinking about that. It might just be a day-by-day process, so we meet them where they are. But the fact that we can have advanced care planning available, different therapies available, things ready to go, is essential for that household. And a lot of the times, from the carer's point of view, it's confidence to know that they can actually do this, and there are support services around. And as Claire said, there are some wonderful organisations, so we a lot of the time just navigate towards those. NDIS, My Aged Care, they're a lot of fun to get around, as everyone knows. And as far as things happening quickly with them, they don't. So being able to navigate that, get things in between time, have the confidence for that carer to know they can do this, and they can, in every way possible, support the wishes of their partner or loved one, is very important, as long as they know they've got that support before and after. We find that a lot of our work is to support that carer after the services can be involved up until that point, which are wonderful, but as soon as that person does die, the support stops, which is really when the carer needs it the most. What do I do? What do I do now? My whole purpose, not just my husband, my wife, my daughter, my purpose for being here is gone. What do I do from here? So us supporting those people in those roles is essential, and that's what we actually, one of the areas we specialise in. A lot of the times people don't, there is certainly a place for professional counselling and grief counselling, but a lot of my week is spent just sitting with people with that grief. They want to sit there and talk to someone who has been through something similar, not the same. I don't know what anyone in this room has been through, but being able to sit there with them whilst they talk, or just be there. That's essential, and it's rather a large area of what we do as far as support for the carer.
Thank you. Yeah, would you like to? Yeah.
So I think it's just a couple of comments. One is there is a percentage of people who do not want to die at home, and if you look at the population data, it talks about 70% of Australians want to die at home, when actually a small amount of data addressing people who are actually faced with the scenario of spending the last part of your life at home, that actually percentage falls. And so some people just do not want to die at home, and we need to make sure that they don't feel that that's the wrong decision to make. The key isn't dying at home, it's dying where you want to be, and that isn't going to be home for everybody. One of the trickiest things, I think, for families and carers at home is profound confusion and delirium. It's probably the most difficult symptom, I think you'd agree, David, to control in a hospital setting often. And if we transport that to a home situation, it is often probably the symptom that is the most difficult for families and carers to manage, because it's a complete change often in who the person is. It's a completely different person to them. And the other comment, I think advanced care planning is really important, but the key is it's a fluid concept. It's not set in stone, and it's not the piece of paper that's the key, it's the discussion. And advanced care planning doesn't mean do not resuscitate. If we're going to accept advanced care planning as a concept, it includes the desire to go to hospital and have treatment if that's what you want to do. And I think sometimes that nuance gets lost a little bit. And sometimes the discussions you have with people who very clearly say, I want to be at home, And then you present a scenario like, well, what would happen if you got an awful chest infection that wasn't responding to oral tablets? Would you want to go back to hospital, or at least think about going back to hospital in that scenario? A large number of people say, oh yeah, that's obviously what I would want to do. So advanced care planning is really important, but it's also very nuanced, and I think it really needs to be thought of as a fluid concept, not something that is set in stone the minute someone makes a decision.
Yeah.
I think one of the other really important things to remember with advanced care planning is that there is a section in that document which talks about the patient's values, the things that are really important to them, you know, the people around them, the things around them. So to me, as a nurse working in this area, those are much more important conversations to be had, because no one really knows at the end of the day whether a death at home is going to be achievable, even though we might strive for that if that's what the patient wants. I always think of it and tell patients and families, it's not a failure if you're not able to achieve that. It's not a failure at all. Any time spent at home caring for somebody is a win, because it is hard. It's 24/7 and it's a relentless job. So getting back to the advanced care directive, really important stuff to know, helpful to know. It is fluid, but more importantly, the values that that patient can actually articulate. That's a much more valid conversation, in my opinion.
Yeah. And Claire, did you want to finish this question? Did you have some thoughts about this? It was just about this conversation.
This conversation. Okay, not about that question. Okay.
No.
I absolutely agree. And often when we're doing talks and community sessions about advanced care planning, we say the piece of paper right at the end is you know, something, but again, everything is subject to change. We're talking about the advanced care directives, those 2 pages of values, that's the gold. That's the bit that at 3 o'clock in the morning you can't get from the medical record, and then that can guide you so that you're not putting all the options on the table, because you're looking at it and saying these are the only options that fit with this person's values. I'm speaking to the converted again because I know there would be a lot of advanced care directive discussions happening, but I think having those talks early, once you've hit the ED doors or the palliative care unit, we're kind of missing the point. And I think having the discussion early is really important. I just wanted to say I thought that was interesting that it came from the doctor about the wife's suffering, and I think the doctor's suffering is showing through here as well. And I want you to all urge you all to look after yourselves, because this is hard. And I don't know about you, but I'm pretty tired. And I think that's something that we need to reflect on and make sure we're doing our own self-care as well. I know it's become a buzzword. I won't say the other rude word I said before, but I think you need to be able to find those ways of recharging your own batteries so you can care for others and be in these difficult situations and these difficult conversations.
Well, that's a lovely introduction for tomorrow's online session, where we're going to talk about GP workforce burnout. That is the word, isn't it? Yeah, we didn't want to say. And I think that pivot point around what is reasonable, and I liked the way I think we all described the various elements of reasonable in terms of what's reasonable for the doctor, for the patient, for the person who the support needs of the carers, and also around what we expect of a planning document and the values that are part of that. So thank you, Deb. There's one more question that I'm going to throw to you, which is hopefully the cause of death. Well, we've got to go. Just death certificates in this context, in the context of COVID, would the cause of death be cancer or COVID?
Oh, I was going to say the cause of death is COVID for any death that actually has occurred when COVID is an acute illness. The top, you know, for those of you that are used to doing death certificates, we've got the top cause of death and then events leading to that. The top cause of death in most cases is COVID, with the underlying things below that. But that's not necessarily the case if it's very obvious that the cause of death is a complication of the terminal disease. Yeah.
Thank you. All right, thank you. That is all we have got time for today. Did you want to say?
Can I just say one thing, please? Oh. No? Yes.
Yes, you can.
Just Geelong Special Interest Palliative Care Group has a breakfast meeting once a month, and I know that Ballarat also has a Special Interest Palliative Care Group that meets once a month. We are open to newcomers. We would welcome your presence in our meetings. Ours in Geelong is a breakfast meeting, Tuesday morning between 8 and 9 at a local cafe. We have case presentations, we have guest speakers, we have just general conversations, usually involving palliative care. So you are all welcome. If you've got any interest in it, contact myself in Geelong or Ingrid, who's at the PHN, and David runs the Ballarat ones. So,
thank you. All right, well, that brings to a close today's session. Please, thank you for completing your post-conference evaluation. You'll find the link on the homepage. It will be emailed you. Please put in your input for next year's session. Certificates of attendance will be emailed for this session that you attended. Thank you to today's speakers and organisers. We look forward to seeing you back here at 9 a.m. in the morning online, where we'll hear from Adjunct Professor Ruth Stewart, National Rural Health Commissioner, Australian Government Department of Health, who will kick off the day's program. Our keynote speaker will once again be followed by an assortment of GP and primary care sessions, along with plenary sessions on First Nations health in primary care settings, innovative ways practices are managing patients during the COVID pandemic, and of course that workforce piece on looking after our workforce. So thank you. We'll see you then. And thanks everyone. Nice to see you all live face to face and across all the venues. Take care.